so you know. Where's Najaf? Yep.
Do you have the names or the list of things or no?
Oh, I got it here. I mean, for you?
Yeah, I just
for the names,
figure out who it is.
Has it the app?
Are you gonna,
So here's it's Najaf. It's going to start. Brian Courtney is second.
Brian Courtney? Where is he from?
Coup de vélo, là.
Are you gonna make a presentation, like ask him to present? You want him to? Just trying to find you here. Because I have your email.
Is this far forward and backward? I don't see a computer. So how can I control the OCT? Because I don't have a computer there.
I have.
I'm just trying to send you this thing.
Oh, no. Yeah, they'll just let it run.
Because usually I have the computer right here. You would
Yeah,
click
that's
on
what
and-
I usually thought of. I have my computer. If they can connect it there, I can do that.
Yeah, no,
That's right now. Yeah, and then this, I can see there. Okay.
yeah.
20 minutes?
Okay.
15 minutes?
20 minutes total with
I will
questions.
probably, there's not much in the case. I think it's mostly for discussion. Yeah. So what I'll do is I'll just go a few slides and then two stations in between.
Yeah.
Where you just open up for discussion.
Yeah.
And what people think about it, what should be done. That's it. And then I'll tell you what we did.
Okay. Well, good afternoon, everybody. Bon après-midi, tout le monde. Bienvenue à, je ne sais pas c'est laquelle, peut-être la 30e édition de Controversies, qui est subventionnée par le CAIC. Welcome to something like the 30th edition of the CAIC Controversies in Coronary Angioplasty session. My name is Don Palasitis. As you know, we've been the three of us with Dean Trabulsi and Sam R. I call him Sam R because I can't pronounce his last name ever. We've been co-directing these sessions. And Hung, being the president of the CAIC, has been helping us also. Comme vous savez, ça fait plusieurs années qu'on fait ça avec Dean Trabulsi de Calgary, puis Sam R. Qui vient de Toronto, avec Hung Lee qui vient de l'Institut de cardiologie de Montréal. We do a lot of acrobatics in the cath lab, as you all know. You're all high volume operators here. And the equipment we use is usually amazing. However, it's not perfect. And I would say that the theme today is how to deal with equipment that doesn't react the way you would like it to react. So we've got 4 really great cases. On a 4 cas assez intéressants là, de problem solving à l'intérieur de la salle démo. Je pense qu'il va aider nous tous là, à apprendre et devenir des meilleurs opérateurs. I'm going to ask for the first presenter to come up. Najav is from Dalhousie, and he's going to set up and present the first case. Usually, as you know, what we do is we have what's called an alpha moderator for half the session. So the first half will be by Dean Trabulsi. The alpha moderator, goes around, makes sure that the speakers stay on time, and also takes comments from the crowd. Hung will be circulating also, taking along with myself for those who have comments that they want to share with the group. This is meant to be interactive. Hein? C'est supposé d'être interactif. Fait qu'on veut des commentaires parce que tous les experts sont ici en salle, pas juste ceux qui présentent. Did I forget anything, Dean? Sam is here? Okay. Sam has made it. He had some airplane issues. Sam, can I ask you, while Nadine is setting up, just go in the back and they'll give you a roving mic. Thank you. Thank you very much.
Thank you, Don, for providing this opportunity to present a case. Normally, this session is basically meant for complex, really exciting cases where we've done a lot of heroic stuff. But I'm a straightforward person, and I have a very straightforward PCI here to share with you. And I'll just stop, and I'll invite more discussion than to tell you what we did. Can I have the slides, please? So this all started with a very straightforward patient. First case in the morning, I think it was on a Friday. Fresh in the morning, in a mood to just quickly get things over and move forward. And this is what happened. 81 years old woman presented from one of our local hospitals with typical chest pain for 3 to 4 days, anterior T wave changes, hypertensive, elevated troponins, nothing unusual. Echocardiogram showed mild LV dysfunction with anterior hypokinesis. She was managed along the lines of non-STEMI, uncomplicated stay. I didn't know why they did a stress test, but they did a stress test that was positive at low workload, and she was referred for cath.
Najaf, I'm just going to interrupt you 1 minute. En arrière, s'il vous plaît, est-ce qu'on peut baisser les lumières sur l'écran du côté gauche, s'il vous plaît? Okay, go ahead. Sorry.
Okay. If you want to translate in French, I can stop.
Yeah, no, it's going to be too hard.
Okay, so this is the right coronary angiogram, dominant right coronary artery, very juicy, good-looking vessel. So I was excited there will be something in the LED to fix. And we got it. So focal, somewhat ostial, but proximal LED lesion, which you would like to start the day with. Focal lesion, proximal LED, some impaired forward flow. And we were excited. We'll just be done in 15 minutes. Did the balloon with a 2.5 millimeter track balloon. Got a little better in terms of flow. Got the stent there, resolute integrity 40 by 22, deployed well, looks nice. I thought that this is not perfect. We make it a little more optimized. Try to do a post-dilatation, opted for a 4.5 millimeter balloon. The balloon is sitting there. And the next thing is, after post-dilatation, I was unable to deflate this balloon. I was trying to get this back, got stuck into the left main, and patient got started chest pain. She was restless. She was dropping her blood pressures. STs were going up. We were all having some VT episodes for ourselves. So the question is what to do.
Okay.
So
I'll invite some some discussion and some opinions here.
There's a high-powered table here, so I'm going to lean on Chris Overgaard here to tell us how he would solve this now that he's shifted area codes.
Well, thank you, Sam. Radhakrishnan is the last name. So I think I've had this before, but not in this location. It's quite horrifying to see. Thing I would consider right away is whether we may have to pop this balloon. First of all, I would try to pull harder, as Eric said beside me, as the first option. But if that didn't work, I would actually try to take a very stiff CTO type wire, like a Confianza or something like that, and try to actually poke into the balloon to see if I can to actually pop it, to see if it will shrink after that. There's a downside to that because it may not actually collapse properly.
I can tell you something, they are impossible to pop. Impossible. We tried it, we had the same situation with a circumflex. We worked for, I think, 4 hours trying to pop with everything you can imagine. And at some point, the tech I was working with said, guys, look at me. He had the balloon on the table, another one, and it was trying to pop it with the wire on the table, right on it, was impossible to do. So, to be honest with you, right now, the best thing to do, I think, is to blow out the balloon by turning your indiflator to the maximum.
The only, I agree with you actually, but the only problem is the location of that balloon makes me a little nervous, but probably the only way.
So one thing you could do often is because something dye is going to be locked in the inner tube, you can cut the end of the shaft and take a wire, the back end of a wire, and push it as far as you go. And this may unblock and then you're going to be able to
exchange the
deflate.
wire or something? Is that what you're saying?
Sorry.
Exchange the wire, or
No,
just
no,
put
no.
it through
You cut
injector?
the part where the inflator is connected, and then you use the back end of another wire, and you just go as far as you go.
Through the balloon
Just
port.
through the
So we spent a lot of time on this because we had a critical incident about 6 months ago, and it was with a stent delivery balloon, where exactly the hypo tube, something must have happened between the inflator. We did all the usual things. We cut the tube, nothing happened. It was again in a very critical position. Afterwards, we played like you with everything to see if you could have anything that would come down and puncture that balloon. But the way the balloon is shaped, it just deflects off. You would have to be incredibly lucky. As part of the critical incident, we looked into the literature out there. So there are rare cases, as you know, of stent balloons not going down. Now this was a post-dilatation balloon, so whatever, who knows. But really all you can do is hopefully by overexpanding it, have it blow it up, and then just deal with the left main dissection or whatever after. But other than that, the patient is in significant jeopardy.
So the only question I would ask you is, where are you going to blow it up? Because right now it's in the left main. I honestly would be tempted to pull my guide, my wire, and lose it all, rewire and salvage a dissected left main versus rupturing the balloon in the left main. So I'm curious about people's opinion about where you do the damage. Do you pull it out and pop it in the aorta? Or do you actually pop it where it's sitting right now, which is in the left main, which I wouldn't do?
So we tried everything with ping pong guides and all of that to pull it out. I think absolutely, Rob, that was the first strategy. But when that didn't work, despite very vigorous guide going right down to where the balloon was, then it was purely just overinflate it till it bursts, because I really think that's your only option at that point.
There is,
Go ahead.
yeah, sorry, there is maybe something, as the balloon is stuck very proximal here, to take another axis and to go with the 8 French guide and a bioptome and try to, take a piece of that and deflate it there.
Okay, so good suggestions. This is not in mid-to-distal LAD or mid-to-distal circumflex or an RCA. This was like in left main, and she was going down in front of me, and I had no idea what to do. Desperately, as we always do, call the surgeon, but I was not sure what the surgeon is going to do at this point in time. Quickly try to take the inflation, just fill it with more saline, try to sort of dilute the contrast if we can. That's what I can do. I took a coronary wire from the back end and tried to poke that up through the catheter into the balloon, but I knew that this is a non-compliant, pretty stiff 4.5 millimeter balloon. It may not happen. The idea about bursting didn't came to my mind at that time, but even if that was there, I would have been very hesitant to do that in a left main situation. So, it's something which is reported, but it's pretty hard to make that bold decision to rupture the balloon in the left main. So we were desperate. We were lucky as well. What we did was we were just trying to pull it, and we did few things like change the saline, try to decompensate, move around the catheter a little bit if there's a kink in the shaft or something, and then keep on pulling. And we were lucky enough it just pulled back. So wire and the balloon came out, and you see the catheter hanging into the ascending aorta just below the arch with the coronary wire there. Now, we could have cut the shaft as well. I was a bit hesitant about that because once we cut the shaft, I have no control about anything. So, it was a quick few-second thing. As soon as it came out, patient got better. She was stable. Chest pain got better. STs went down.
Did the stent stay in?
Sorry?
Did the stent stay in?
Yeah, so I'll show you what happened to the stent. We were aggressive in taking this out. So, well, actually, you go back and can I go back to the slide, or let's just we looked at the angiogram in the last slide. So there was a bit of haziness in the stent, and so what I decided was just dilate that a little bit more with a 2.5 and 3 millimeter balloon, and then we thought we'll see what happened because I just missed that angiogram. There was a lot of haziness around that area. So we started to do the OCT, and I don't have control over the ACT, so we'll just wait for it to run. But what we saw was exactly what you expect, that the stent was distorted and came back. It was completely distorted and came back halfway into the left main and was hanging into the left main. So I'll let you see this picture before I move forward. It's full of clot, segments are dissected, stent is distorted, and it's hanging partly into the left main. The wire is out. So, but we have time. She's completely stable, and she was asking what happened, and I said, no, nothing, just power failure.
Najab.
So we'll explain to you later on.
Najab, you have you brought this up with a second system, is that correct?
Oh, yes, yeah, sure. So we left the hanging balloon into the ascending aorta. We got the femoral puncture, and we got the new sheath and everything new. So we rewired it and ballooned it and then put the OCT catheter in. So I'm not sure that you got that, but that's what it was. So the stent was open, distorted, so we decided we'll go with more 4.0 and then 4.5 millimeter balloon. This was not an NC, this was a regular balloon. We make sure that the contrast is fully diluted. And then did an OCT again one more time. Stent got a little better, but it was hanging into the left main, and it didn't look nice. So what would people do here while it's running?
I mean, I think if you look at the initial deployment, the stent was partially in the left main, but I think it was pulled further when you were trying around. And obviously, you have an issue now. You have to decide whether, are you fully opposed in the left main or no?
Well, to a certain extent in the LED, but in the left main, it was still distorted and it was hanging there. So what we decided was, if you can see the pictures, this is still like not fully deployed, and this is 4.5 millimeter balloon. So I think it was broken and it was not getting it. So basically what we decided, we'll just put one more stent in there. So we put a 4.0 by 33 and then post-dilated that again with a little hesitancy, but took another 4.5 NC balloon and then a 5 millimeter balloon. And
what kind of stent? Sorry, what was the stent?
Zynes, this was Zynes.
Just regular Zynes?
Just a regular Zynes, yeah.
A 4 millimeter?
4.0 by 33, yeah. And the final result was pretty good. So the stent was deployed well, the left main looked nice, everything was good.
Can I have a show of hands? How many people have had experience non-inflated balloons? So it's a common problem, it seems, and just to wonder whether specifically with the NC balloons, or is it the regular deployment balloons, stent deployment? Yeah, how many were stent balloons? Yeah, like initial stent deployment.
I think this is a very good, important question, Dean, because we had few cases in our center, and since then we have removed the Trek series and we have changed it to Solaris. Not sure if that's going to change the things, but we have quite few. Lawrence had couple of cases. I had one. The one more operator had one more case, so we changed the inventory from Trek to the Medtronic balloons now.
So what do you think is the mechanism then of the Najaf right here?
I'm actually not hearing anything. That's the reason I went back down.
What
So-
do you think is the mechanism for the stent, the balloon not coming down? Do you think it was a kink in the shaft? What do you think?
You know, we sent this balloon back to the manufacturer. They didn't come up with any suggestion. The balloon to them was fine in terms from the industry standpoint. I can only speculate. You know, the contrast may have been dense. I may have been a little quicker. You know, since this procedure, what I've been doing, I've been doing some extra seconds once the balloon is deflated to pull it back into the catheter. And I'll show you at the end the pictures how the balloon looked like. But it could be that the balloon was not fully deflated, and I just pulled it against the catheter and distorted the balloon itself, and then it failed to come in, and it just blocked it. So it's all speculation. I don't know exactly what happened. So
Najaf, we have
So
2
there's just-
minutes.
yes. So
There's no consensus because you send it back to the respective industry, and invariably you get back when you look in the case reports just that there was no issue. It's got to be something in the hypotube between where your inflator is and your balloon, but again, that's what we were told during this critical incident was, oh, you must have done something with the dye, but these were very experienced cath lab nurses, and it was the same way that all of us do this 10,000 times a year, right? So I think there is something there, and the question is how big an issue it is.
So in any way, the angioplasty results look good, but then the second problem was that this balloon was still hanging in the aorta, and what to do with that. So any suggestions?
Yeah, we got one here.
I've had to deal with this twice, and probably the best option is to snare it femoral through a large sheath.
Snared?
Yeah.
Yeah. So
Or deflate with a snare. You
Yeah.
snare, pull, deflate.
So that's what the suggestion. I put another extra femoral sheath in, and I was trying to upsize that to 14 millimeter. I was thinking I'll put an AST delivery sheath or something, get a snare there, cut it from one end, and just snare the whole thing out. But while I was doing that, the other operator was trying to pull it against the catheter, and we saw that the shaft was getting out. I think the plastic was sort of stretched,
Bad
and
news.
and it was breaking. And you see that the balloon was deflating there. So balloon is against the catheter tip. It is deflating. It's not still coming back, but it may have been broken because we sort of pulled it out. So what we did was we put one more balloon inside the catheter to secure it, and then we just pulled it back.
That's the larger issue, is all the stuff you do to get it out, but then when you send it to industry to look at it,
It's distorted.
Yeah, so it was all distorted, and it's just coming back all the way, and it's just nicely coming out through the radial. And then we put a TR band, and it was good. You know, there was no issue. The vessel was great, and there was no issue with there. This is how it looks like.
Just before you go on, one other option that has worked once in the past is a bioptome. So the same things, if you can actually fish and get it with a bioptome, you can actually maybe pop the balloon with a cardiac bioptome for doing biopsies.
Yeah, I think it's possible. I was not sure that bioptome is long enough to go from the femoral all the way to the arch, because they're usually for the right side, and they're 70 to 80 centimeters. I'm not sure that we have a long bioptome. So that was the only concern I have at that time. So in any way, this is how it looked like at the end when we retrieved it. It was still stuck there. But that when I pulled it out, the plastic shaft was elongated, and I can see that the break was there where the plastic meets the metal there, and you see that it's dripping there. So
Well, thank you very much.
patient did well, no issues. Aspirin ticagrelor, this is 1 year, maybe scan, doing great at 12 months follow-up.
Thanks very much, Najaf. That was great. Do we have an obligation to report this to the
Brian?
Canadian authorities? Have we fully reported? Are we done that? Is everybody does that? I think we all should do that, because unless we have reporting, and there will be no follow-up, and we'll know the numbers, and we would not know the incidents and the rest of it. Yeah, no, absolutely. So I will encourage you to do that if that happens. Our next presenter is Brian Courtney. Brian.
Hi, thanks. I'm Brian Courtney. I'm from Sunnybrook in Toronto, and it's a pleasure to be here. Once my slides come up, I'll present to you a case of a complication in a patient with very calcified coronary disease. I do have a disclosure. I run a company that makes intravascular imaging devices, and I use one of those in this case. So this is a 62-year-old gentleman who's had prior bypass surgery. He's got hypertension, hyperlipidemia, diabetes. And his bypass surgery was performed at another institution, and within a year and a half, he had recurrence of class 3 angina that was refractory to medical treatment. He had a stress test that showed some inferolateral ischemia and was referred to a community hospital for coronary angiography. And the repeat coronary angiogram revealed that his lima to the LAD was patent with a collateral to an OM apically. There was a 70% distal left main lesion, a diffusely diseased circumflex. The left main lesion is perhaps a bit better seen here. And the RCA had evidence of flow in the proximal mid and distal RCA. There was also some flow in a PIV and the right-sided posterolateral branch. Just want to get that to play again. Can this play again at the back?
On peut jouer, on peut cliquer sur l'image. Merci.
And so this was a bit of a zoomed out view. It'd be nice if there was a bit more radiation use here to see things. There's an area in the proximal PIV that's not really clear exactly what it was. Now the graft anatomy was a vein graft to an OM, a lima to the LAD, and a skip graft to the PIV that then skipped to the PLA. And that explains a bit of the unusual appearance in the distal end there. So heart team rounds at the community hospital decided that we should proceed with an attempt to the distal RCA, probably with a bifurcation technique. And initially, the angiogram suggested there was an antegrade microchannel from the distal RCA across the crux and towards the lateral wall to the right side of PLA branches. I brought the patient back for coronary angiogram and for that attempt, and I couldn't find the microchannel. There was a discontinuity between the distal RCA and the ongoing RCA distal to the crux.
Brian,
There's
could
also,
I stop you for a second there? Do you think like this connection here, it looks like a vein graft to me?
So that it turns out that that is actually a skip graft from the PIV to just distal to the crux in a very unusual location.
Yeah, so different views might have helped you decide whether there's continuity or whether that is totally stopped and then there's a graft, because that's a situation where some problems will occur if they did not.
And I was trying to get different views of this and had a hard time sorting out, was it I was 80% certain it was the graft between the PIV and an unusual location, I would say, within the AV groove, because normally they would skip to something a bit further away from the AV groove towards the lateral wall, at least at our institution. So I stopped there and I said I want to get a little bit more information about what was going on, be really sure that the OM graft was down, understand the graft anatomy a bit better, because I was going to be jailing either the PIV or the PLA potentially with whatever intervention I did. So we aborted it. I did a CT coronary angiogram and got some good assessment of the fact that the vein graft to the OM was occluded, the vein graft to the PIV was occluded, confirmed it was indeed a skip graft, and also got some useful information about the extent of calcification within the RCA, and I often use this to help me decide if I should be using rotablation up front or not, depending on the degree of circumferential calcification. So we decided to proceed with another attempt. I did 7 French femoral access with a fairly supportive guide, and my plan, because of the competitive flow in the PIV and the diffuse nature of the disease in the PIV, was that I would consider the ongoing RCA towards the lateral wall to be the main branch and the PIV to be the daughter branch. It was actually fairly easy to cross over to get into the PLA, and we started using some balloons. I was able to get 1.5 millimeter balloons into the PIV, but I was not able to get a 2.0 millimeter balloon into the PIV. I was able to do some predilatation with the 2.0 millimeter balloon into the ongoing RCA distal to the crux. And I started getting fairly aggressive at using balloons here to try and pop things open. This is a 2 millimeter balloon here, and this is when my problems began. You can see that there's a balloon in the mid to distal RCA. This is after I've tried to deflate the balloon, and actually this is while I was inflating the balloon, the pressure in the insufflator went down to 0. And I didn't see any staining near the balloon. And as I retracted the balloon from the RCA, there was 0 resistance, but the balloon was not moving. So I ended up with a shaft on the table and the distal 30 centimeters of the catheter in the guide and in the RCA, wondering what to do next. So the patient was having some chest pain discomfort, some hemodynamic, they were stable, there were no ECG changes, gave a bit of pain control medicines, made sure the ACT was in a good range, and I wanted to remove the balloon without losing wire position. I was a bit eager to keep going on with this, but I actually couldn't see the shaft. I had no idea within the guide where it was because it's radiolucent. So I wanted to confirm where it was and use that to help me guide things. And my original plan was, let's identify where the shaft begins and ends, and then let's also see if we can advance a guide liner over that shaft, so maybe I can put a balloon trap to try and pull it back with a guide liner without losing my wire position. In order to determine where the shaft was, you can see the shaft at around 1 o'clock. I advanced an OCT catheter into a contrast-induced guide. This was without any guide wire on the OCT catheter itself, similar to what you do for balloon trapping. And I was able to quite nicely visualize it, and there you see the guide liner coming in and out of the field of view. And I unfortunately was not getting the balloon shaft to fall within the guide liner because I had a 7 French guide and a 6 French guide liner. So this unfortunately was not an approach that was going to work. I then tried to snare it with a 3-loop snare, and that was with the sheath for the snare in addition to the neighboring equipment, but I couldn't fit the OCT catheter and the snare in simultaneously, so I wasn't able to visualize it. So I just tried fluoroscopy guidance to do this, but I had a hard time determining if the shaft was indeed within the loops of the snare as I was trying to pull it out.
So you're snaring it outside the, like
Sorry?
trying to snare it in the coronary or within the guide?
Within the guide. So I had established, based on using OCT, that the shaft was within the descending aorta, just past the origin of the left subclavian.
Any other suggestions? One of the things you could use is use a trapper
Trap
balloon.
liner.
Just put a trapper in the end of the catheter.
So I knew that if I wanted to give up my wire position,
I think that would be probably the
Yeah,
most kind of drastic decision.
I knew if I wanted to give up my wire position that I could just go in, throw in a 2-millimeter balloon, trap it, and pull all my equipment out simultaneously. Because it was so calcified and I'd used a lot of balloons, I was trying to preserve my wire position for the ongoing procedure.
I understand.
So what about using a 3-0 balloon? Make sure that you're tapping that shaft right very stiffly in the guiding catheter and then pulling a little bit to see if things starts moving a bit.
So that's exactly what I did. So what I did was the other option I could have tried was doing a wire wrapping technique. What I did, you can see the snare there. It wasn't clear when that was going to work. So what I did was I actually delivered a 2-0 compliant balloon into the distal portion of the guide, inflated up to 8 atmospheres, and that applied just enough pressure to be able to then pull on that second balloon, and I was able to watch. Unfortunately, I didn't fluorosave it, but it was very cool to watch the fragment of the balloon come out of the RCA and into the guide, and now it's in a more safe position of the guide. And here you can actually see when I'm trying to pull it back a little bit with the retrieval balloon that some of the catheter is moving. Although once the shaft got to the femoral bifurcation, was heading towards the manifold connection, or sorry, to the tubular connection, it then got stuck at that point because it was getting cut on a lip. So at this point, we decided to just pull all the equipment out, and there's a picture of the portion that was resident within the RCA and the guide. And then took a final picture here. We had TIMI 3 flow going in all directions. I'd reestablished continuity between the distal RCA and the ongoing RCA distal to the crux. And it was a 3-hour procedure, 210 cc's of dye. Everyone was comfortable, myself, patient, and the fellow included. And we just considered this to be an investment procedure and thought we would bring the patient back in 4 or 5 weeks after the micro dissections from our initial predilatations had healed.
Can I stop you for a second? What did you think happened?
I think that, so I went up to 24 atmospheres with the non-compliant balloon. It was an NC emerge. I think what happened was, I was 8 atmospheres above the rated burst pressure, and I happened to be the 1 in 200, which would fail above the rated burst pressure. So it was actually burst in the, it was a bond between the stiff portion of the shaft and the more flexible portion of the shaft that's intended to be delivered into the coronary. So that bond site was a point of failure.
Okay.
Patient presented to the emergency room about 2 weeks prematurely compared to what we were hoping for. So I took them to the cath lab the next day, and we rotabladed into both the PLA and into the PIV. We were able to put stents in from distal to the crux. I just put a wire protection to the PIV, sent it all the way back to the os of the RCA, got a good result. We fixed the left main and the circumflex as well. And checked in with the patient, and this patient who had refractory angina is now doing quite well.
Well, thank you very much. That was excellent.
So I think I learned a few things here. Certainly the skip grafts add some complexity and are prone to early failure. That's something we're all familiar with. I'd never seen or heard of the balloon actually breaking. Normally, we see them rupture all the time when you're doing calcified lesions at the balloon itself, but I hadn't seen the balloon shaft fall apart during the procedure. And then it was a bit of a new use, I suppose, for OCT in terms of identifying radiolucent equipment within the vasculature. Okay.
Thank you.
Thanks.
Great.
Sam, it's your turn.
So, thank you. So, our next presenter is Olga Toleve. How do I pronounce your last name? Toleve. Obviously from Winnipeg. I haven't seen your case, Olga, so I'm in the dark here, but I'm sure you'll provide a lot of light.
Okay, well, first of all, thanks for inviting me tonight. It's a great honor and pleasure. This was our first case of a type of technology that is very exciting. So I just see, oh my, this is quite advanced from what it's supposed to start. Could you maybe ask them to start from the
On
beginning?
peut recommencer dès le début, s'il vous plaît?
Okay, well, I could tell you the story of this case. So this is an
Ouais. Non, recule encore, s'il vous plaît.
88-year-old woman with a new diagnosis of severe aortic stenosis. She presented to our hospital after a recent echocardiogram, which showed the aortic stenosis with a valve area of 0.9 and a mean gradient of 35. She had acute episode of chest pain with troponin elevation and ECG changes, and was admitted and be treated for acute coronary syndrome. During the admission, after the discovery of the severe aortic stenosis, we decided to proceed with an angiogram, including TAVI angiogram shots of the iliacs and a CT scan to assess her anatomy and eligibility for TAVI. As you could see here, not a surprise for an 88-year-old vasculature, you see very calcified LED diagonal bifurcation with the presence of an aneurysmal dilatation right at the origin of a large diagonal branch. Distal to it, there was also significant calcification, which appeared quite concerning. The circumflex artery was also very tortuous and calcified, and the right coronary artery was a codominant system, which was diffusely diseased and calcified. You could see the cast of calcium of the left coronary system visible on the right coronary shot. At this point, I stopped and discussed with my colleagues the options to approach this patient's case, specifically discussion about the presence of aortic stenosis, the candidacy for TAVI, and the possibility of percutaneous revascularization of the coronary system prior to the valve procedure.
So maybe
we all
I'll
agreed that
maybe
at
I'll
this
stop
stage-
you there, Olga.
Yeah.
And obviously it's a more common phenomenon now. Very old patients coming in with ACS. How bad was that valve stenosis? How severe was it?
The gradient on the echocardiogram was 35, but the valve appeared severely calcified, and visually, when they estimated the valve area and looking at it, appeared severe.
So obviously, at this time point, it's the question of whether you think this is all related to the progressive aortic stenosis, or do you think this is underlying bad, maybe even ruptured plaque, CAD, that warrants intervention? And
David?
I think that's
Yeah.
a crux discussion.
We'll ask David here, he's our valve expert. Would you do TAVI without
So, so this is truly the billion-dollar question, I think, in the next 5 years. So did this patient have ACS or no?
She did, yeah. She had
Yeah.
troponin elevation, dynamic ECG changes, chest pain, but also shortness of breath, which was progressive for the last 6 months.
So in stable outpatients, we'll talk about it a bit tomorrow, and then we're announcing it in the next few weeks. We have a 3,000 patient trial looking at this, basically transfemoral TAVI 1,500 to concomitant PCI stage versus not. The exact same thing we did with complete with ACS, we're
Yeah.
going to do with stable outpatients. Now here, this patient will be excluded because they're coming in with positive biomarkers. So now you're in that difficult situation where you're trying to figure out what's the main player. We think obviously usually it's the AS as the hemodynamic driver, but this is a difficult situation.
Yeah.
I must say that LAD does look ugly.
And this is exactly right. Our conversation during the TAVI meeting was, well, why don't we fix the coronaries and then we'll reassess her for the TAVI. We'll see her in clinic. We'll see if her symptoms improved and then take it from there. We all agreed that we're not going to attack the right coronary artery at this point because we felt it's diffusely diseased, small territory, and very calcified. But we definitely wanted to do something about the left coronary
So
system.
Olga, did you have any idea from the ECG what the culprit lesion was, or not really? You just sort of based on visual anatomy decided to...
The ECG was anterolateral T-wave inversion with some lateral ST depression. So I think it was hard to decide whether the circumflex or the LAD were involved. The inferior leads were not involved. I did not bring an ECG, but take my word for it. And again, there was big argument between me and Malik, as usual, whether we should do the TAVI soon or not, and we continue to argue about it.
So if you've decided then to attack the coronaries, I'd like to sort of find out what the people are thinking here. This is, in my mind, very close to a prohibitive percutaneous case, given the fact that you're going to leave the severe aortic stenosis. You're not going to put this lady on any kind of mechanical support, I don't think, at 88 years old to do the procedure. So it's one of these cases where I think we're ready to lose the patient on the table. So we can refuse to do it. I mean, that's an option. And if we do, however, do it, how would we prepare this case? TAVI first? You're a TAVI first guy? All right. Not usually. S3, so you don't protect the coronaries.
So normally I would do PCI first, but in this situation she has three vessel disease, severe AS. It's a complex PCI, large territory. As you said, if as soon as she becomes ischemic, things are going to go down. We're not going to put an impella for the procedure. So I think if we want to give us our best shot to fix her coronaries, then you have to fix her valves because she's going to be able to tolerate more ischemia. And we were saying SAPIEN 3 because having a shorter valve, you're going to keep access to the coronaries. You're going to be able to use our usual guiding catheters, having more support. So I think if we want to go through, I think this is for her would be the better option.
Another comment?
Great case, Olga. Had she had a CT for TAVI planning at this stage?
Yeah,
Did I miss it?
we completed the full workup. So she was a 26 millimeter SAPIEN 3 if we decided to proceed with TAVI, and we have these available if we need to.
And the burden of calcium through her iliofemorals and aortic arch and all of that, was it bad or not so bad?
It wasn't very bad. No, her iliacs were a good size and they were not very calcified, and the arch as well. So she would have been a good surgical candidate if, like from this type of perspective, porcelain aorta or any issues related to this.
Yeah, because sometimes, you know, you think it would be nice to have the aortic stenosis not there when you do the high-risk PCI. At the same time, if you put in a $20,000 valve and then you kill her during her PCI, then is that a good use of resources? So really, this is a very, very difficult case, and I'm not sure what the right answer is. But the temptation would be to not have the valve stenosis there when you take on this complex PCI.
We have a comment here, two comments.
Just one suggestion. I don't know if I think the main driver of prognosis in this patient is the LAD lesion, right? And did you think about like a robotic Lima, which is minimally invasive, and then proceed with TAVI subsequently?
Sorry, I couldn't hear.
Lima, minimally
Yeah.
invasive Lima.
Yeah. So this was brought
Yeah.
to the patient, and discussion was undertaken with her and her family about potential need for open heart, or if there is an emergency situation, what would the bailout be? And the surgeon was okay with the emergency bailout if that was the issue, but the patient really did not want to go for an open heart surgery. So we respected the patient wish at this
So I think one, Don's point about maybe this is someone we should just treat medically, consider a palliative approach first. Second, this issue for all of us, whether you're implanting valves or not, is going to become more and more common. It goes from 18% concomitant coronary disease in the low-risk patients up to 76 in the extreme and high-risk patients. So overall, it's 50%, which is almost identical to what you get with multivessel disease and STEMI. So that's why the trial we're talking about, this complete TAVR, is going to look at this issue. And then the biggest question is, which valve? Are you using a short frame annular? Again, I don't care which valve. Or are you using a suprannular valve? Because I think we are all starting to see in the last 12, 18 months, when these cases come back and you've got a suprannular frame, it is not sometimes easy to get access. And we're having to use all sorts of funky guides and techniques to get support to do PCI on these patients. So to me, that's even a larger question is, if you do decide to do a TAVI first strategy, how well is that going to work?
We definitely felt strongly about revascularizing her first for a couple of reasons. Number one, she came in with ACS, she had severe disease. Malik had doubts about the gradient, so we were going to do this first and then decide on the valve. But we were ready to perform TAVI if that was necessary because we have it on the shelf and we could prepare it very fast if we need to. Our PCI strategy was OCT imaging to document the calcification and assess the extent of calcification and deployment, especially in the presence of the aneurysm. And to do an initial attempt to predilate the areas of calcification before we proceed with shockwave to treat the calcifications. We had a great debate about what type of strategy to use for the calcium. And we were a bit concerned about using rotablation in the area of the aneurysm with the risk of perforation. So we felt that shockwave is probably a good alternative option. And our plan was initially to avoid the aneurysm and just treat the distal area below the aneurysm. Well, you'll see what happened afterwards. So this was our very first shockwave case in our lab. So it was very exciting. Everybody was there. And of course, it was not straightforward. So you could see here, this is just a select image of the calcification. This is not running, but you could see that there is quite a lot of calcium of the circumflex. And this is the console of the shockwave. I know some labs have already used it, and others are yet to use it. If you decide to use it, it's pretty straightforward way to order it and bring it. And it's very user-friendly. So a console, a little connection there that you could potentially isolate with, let me see. Right here you connect, it's just basically a magnetic connection, and then this goes in a sterile sleeve. And then you have the balloons, and the balloons come in, they're all 12 millimeter length, and they can come in different sizes, 2.5, 3.0, 3.5. And you only inflate it to 4 atmospheres, and there is the counter here, so it counts 10 pulses, and for every 10 pulses, a 1 course of therapy. And for one catheter, you could use it for 8 therapies together. So it will count to 10 and then will stop, and what you will see during the count is, it looks like pacemaker spikes on the ECG.
What's the profile of that?
I think we have a question here.
Yeah.
Yeah, Olga, I've only done 2 cases, but my concern just up front would be being able to deliver the balloon. Given the bulky nature. Were you planning to pre-treat to get the balloon down, or praying that it was going to be easy? And also the extent of calcium with the limited 8 treatments.
What's the profile of that balloon? Do you know?
It almost acts like a cutting balloon. It has this, it's a bit more stiff than a regular NC balloon, so it could be challenging to deliver. But I tell you what our plan was, and we got so excited about the first treatment that we actually forgot to predilate in the circ, and we were able to deliver it through the tortuosity for the initial treatment. But then for the LAD is when you're going to see that we had some challenges. This is just a simple algorithm by the company of when to use it and the indication for the different types of anatomy that may warrant the use. And they recommend that you predilate before you use the balloon. But there is an option if you are concerned about the risk of complication with the NC balloon that you may avoid that step. And if you're able to deliver it, to go ahead directly with the actual treatment. So this is the actual balloon delivered over the tortuosity of the circumflex, and you could see that it's a bit constrained here. But eventually, we used 3 shocks. So we used a 6 French guide liner. Our guide is 7 French XB35. We delivered shockwave without significant difficulty, without need for predilation, and we treated it, and we used 3 cycles of 10, and we were able to crack the calcium, but then we had a really hard time actually post-dilating and delivering the stent. Eventually we used the guide liner, and we were able to deliver the stent successfully, and we were very happy that it went well on this side. So now we were ready and pre-warmed for the actual challenge. This is the final result of the circ. Everything looked like a piece of cake. We're all like excited. The whole lab, everybody's there congratulating themselves.
Did you choose the circumflex because it was easier?
Yeah, we wanted to warm up to something that's easy. I was really nervous about this aneurysm.
Olga, just remind the audience, how long is the balloon inflated for those inflations, for the shockwave inflation?
How long is the?
Balloon inflated to deliver the pulses.
It's 10 pulses, so that's 10 seconds inflation, and you inflate at 4 atmospheres, and you could do a fluoro during the treatment, and you could see as the shock wave works on the lesion that the balloon eventually expands and cracks. And you could see here in this second image how the balloon is still constrained, and then I'll show you a fluoro where you could actually see it cracked. And you could deliver more than 1 treatment in the same spot and then move forward or backward and deliver
I think you have 80 shocks, right?
So 80 shocks for 1 balloon, and then you have to use a new balloon.
Yeah.
And in some situations, after you deliver the first treatment with the 4 atmosphere inflation, the company sometimes suggests post-dilatation with the same balloon at 8 atmospheres, but not at 24 like you sometimes are tempted to. So just with gentle post-dilation. So here we are in the LED. I thought we're going to use a long balloon just to kind of see what the anatomy of the vessel looks when we inflate and see where exactly we're going to see dog boning. And as soon as we inflated the 2.5 by 20 balloon, it basically burst in the LED. And then we tried an NC, a short NC, and that also burst. And this is just, as you can see here, right at the bifurcation area. So we couldn't deliver a 3.0 shockwave. There was no way. With the burst of these 2, we thought, okay, we're going to use the 2.5 that we already used because we still have 5 therapies left in it. So what we did was, in order to progress, we used the 2.5 and the proximal LED, and then that eventually opened up and then allowed us to cross into the diag and predilate it as well. We did not use the shockwave in the diag. We only used it in the LED. So this is the shockwave, the 3.0, and you could see it, how it is basically constrained in the center and eventually pops up and opens up. Here it is. Now, as you could see, something's starting to happen here. So this is the 3.0 shockwave, and this is in the distal area of the LED, way below the actual aneurysm. It kind of caught me by surprise because I was so focused on the aneurysm. I thought that if we get a complication, it will be there, but it was actually way distal to it. At that point, the balloon burst. So we basically inflated to 4 atmospheres, and we created a shockwave granuloplasty. And this is what we had.
How did you feel about now?
I wish I did the TAVI first.
Or maybe just don't do the PCI.
So much simpler. The patient was fine. She was like, "What's going on?"
Any ideas about what's going on? Was it?
So we.
So Olga, maybe you can tell us what did you think was going on? What did you think?
At first, I thought we just had a perforation. This was the first thought I had, and it did look like it. And we sealed it with temporary with balloon, and then me and Kunal were doing the case. So we just looked at each other and we're like, okay, what we can do here is to save the day is just put 2 stents and do a classic crush, stent the diag that was already dissected from us playing around earlier, and then salvage the LED, and if there is leak, then we could put a covered stent and take it from there. And we were talking to each other, and then the more we were trying to deliver the stents and look at what's going on, it kind of looked like a big hematoma of the wall of the artery. So
Patient stable, obviously.
it was very stressful.
Patient stable? I know
Patient
you're stressed,
stable.
but the
I was
patient-
stressed. My heart rate was 150. The patient's heart rate was 80. Her blood pressure was 170 over 80, and she was just hanging out.
So did you think you had
No
time to
chest
do an
pain.
OCT or an ultrasound to assess the situation and make a better decision?
I did it at the end, so you'll see
I
what
see, I see.
happened.
Okay.
So we stented the diag. We pulled the wire and the balloon from the diag successfully. There was no surprise there with non-deflation. Then we stented the LED. And after that, we kissed. We rewired, we kissed, and we did an OCT. Let's see if, so you could see here that the stent in the distal segment is well opposed, and you could see some calcium spicules and cracks in this area here. And this is the area of the aneurysm. And there was a proximal edge dissection. So what we saw on the OCT is that actually this was all a subintimal hematoma in the area of that extravasation. And here is the actual OCT run. So you could follow it through and see the area in the co-registration that we're going to approach soon here, the actual area of the explosion, which is now completely gone. You don't see any extravasation, but
it looks
you
like
could definitely see in this territory here that there is blood behind the stent and in the vessel wall.
Yeah, at the site of the original aneurysm, right?
Yeah.
It looked like that's where you essentially
But the
tore.
actual extravasation was way distal to the aneurysm, because if you remember, the aneurysm's here, and our extravasation was in this territory, which was the biggest calcification spot of the actual LED on the angiogram. I think what happened was when we delivered the treatment in this calcified area, and we had the granuloplasty, I think it was just like this very potent energy of the IVL together with the burst of the balloon that caused that calcium to maybe penetrate and cause like a focal dissection, which then filled up with blood and caused a intramural hematoma.
I'm curious about the attitude toward an aneurysm and putting a other DS or a BMS. So that aneurysm to me looked very large, and probably you're not going to be able to oppose the walls very well. How many are really of you are sort of, well, we'll just put, if it's a short one, we'll just put a stent and cover the aneurysm and forget about it? Or you shy away from doing it or try to do stenosis before and after? Any comments of?
Who stents across the aneurysm?
So a large aneurysm.
And who tries to avoid the aneurysm? I mean, of course, we have to see the aneurysm, but, you know.
Yeah, no, but I'm talking about a large aneurysm that you are unable to oppose. Brian has a comment.
So I think if you can avoid in relatively simple anatomy, avoiding the aneurysm and stenting it is a good idea. Requires obviously being fairly precise in your proximal and distal edges as you enter and flare into and flare out of the aneurysm. But if you don't have stent, it's really not malapposition that causes stent thrombosis, it's underexpansion. So if you're going from a 3-0 proximal segment to a 2-5 distal segment, and you happen to have an aneurysm in there in the intervening portion over 20 or 30 millimeter length, the data wouldn't suggest, based on IVUS or OCT data, that that's at a high risk of thrombosis. It's more the bigger issue is when you end up in these calcified sections and you end up with underexpansion. That's a much bigger risk for stent thrombosis than I think malapposition in and of itself is. Underexpansion relative to the reference sites at the proximal and distal end of the stent where you have hopefully normal artery.
Yeah, and you're right. And what actually we observed is that within the aneurysm there was a cast of calcium where we couldn't even cross with the 2-0 balloon at first. So really, I think the shock wave really helped by cracking that area within the aneurysm.
In hindsight, would you have maybe thought rotablation? I know you said because of the aneurysm you wouldn't try it, you'd be worried about it cracking, but obviously you can end up with problems with shockwave as well.
No, because I think that I would have been more nervous going with a burr in the area of the aneurysm and not really having good idea where exactly I'm hitting, rather than, in this case, really the aneurysm was not the issue. I think it was the distal LAD that was the problem.
So there are two comments with Don here.
Well, maybe I just want people to pay attention. As we get close to 40, the stent will become very eccentric right there. And this is where we're going to see, I think, the hematoma you were describing, right there.
Yeah.
So I think it supports your idea that the shockwave partially cracked the calcification, which then allowed for penetration and creation of this cavity. And it's showing us where the stent is still not well deployed because there is still residual calcification there.
Yeah.
So I think I agree with your interpretation of the OCT.
What we did was, obviously, there is also a proximal edge dissection that was visible on the OCT and also on an angiogram. We covered that with a 3.5 by 18 drug-eluting stent and post-dilated the whole area with the 4.0 with very good results at the end. I'll show you the final results. This case was done in August, and she is doing better, but she continues to have shortness of breath, NYHA class 3, and now starting to have some PND and orthopnea, no chest pain anymore. So we finally convinced ourselves that we will accept her for TAVI, and I think this is coming in the next few weeks. Since then, I have done another case, and I actually did IVUS on it for the CPI course. And the same, I've noticed very interesting hematoma formation behind the calcium spicules in another very calcified LAD. So I think that the power of this technology, the delivery, the energy that delivers is quite significant, and that the granuloplasty probably caused even more disruption in the area of the calcium. But if I had to do it again, I'd probably just do the shock wave again for this case rather than rota.
I think we have.
It was 6 months ago when I did 2 cases, and at that time, balloon rupture was a frequently recognized problem with this technology, and I think Min was going to try to set up a Canada registry of all the cases, but and I was told that the balloon material was going to be revised. I don't know if that has been done yet, but it's interesting to see it can have this much problem.
So my first case was actually a left main shockwave, which was in retrospect kind of risky. And I had a wire in the circumflex, and when I blew up the the calcium, it actually occluded the circ completely. So I'm not sure if it is just calcium shift or whether it's doing something to the wall, but I think when you've got important side branches, you have to be prepared for that, to actually see loss of vessel completely.
One last comment, and then I think we'll have to wrap up.
Yes, it's just a question from an old guy who's no experience in shockwave, but was there any consideration, because we all know about the significant, exponential risk of restenosis and in a non-expanded stent, especially with a lot of calcium. Is there any evidence or any consideration of using the shockwave within the stent? Because your risk is much lower, so to go back with the shockwave. And that's a question, like I said, with somebody from no experience in this part of it at all.
Brian?
I think Brian has a comment there, so.
So I know quite a few people and the engineers and stuff at Shockwave relatively well. The concern with using Shockwave within a stent is that you'll delaminate the polymer, potentially cause some embolization, and damage the stent. When you have a stent that's underexpanded and it's had some time to heal and you've tried all your other options, whether it's grafting, whether it's just hitting it with a 30 atmosphere NC balloon, whatever you can do, if none of those work, then you don't have another choice. It probably works in about 70 to 80% of those cases to loosen up the calcium behind the stent so that you can fully expand it. I think we've had some positive and negative experiences with that, but that concern about taking a fresh stent and potentially delaminating it is a real one, which is why the IFU currently suggests not to be doing this in stents.
So I think we're gonna leave it there. Olga, what a fantastic case to present at the Controversies session. I personally think there's controversies in terms of whether to have done the PCI in this AS patient, and certainly there's more answers to be found. And of course, we're getting exposure to shockwave, which I think we'll all start to see some successes and some challenges, which hopefully we'll report either in a registry or at these sessions. So our last presenter is Mohamed Nozair from the University of Montreal at the Montreal Heart.
Good evening, everyone. I'm going to present to you Stuck Between a Rock and a Hard Place. I'm co-director of the CHIP CTO program at the Montreal Heart. I have no financial conflicts, and I did this case in collaboration with Hung Lee and our fellows Naila and Florian. So I'm presenting to you a 76-year-old patient known for hypertension, diabetes, atrial fibrillation, had previous TIA, known peripheral vascular disease with a BMI of 45, history of PE, chronic renal disease with dialysis, normal EF, and no valvulopathy. He presented to a peripheral hospital with non-STEMI, EKG showing left bundle branch block. As you can see, he has mild anemia, creatinine of 600, and then he was referred to our center for an angiogram. So as you can see, he has a CTO of the circumflex, which is not a large territory. And in the LAD, there's a proximal lesion, and there's a mid to distal lesion. And you can see collaterals to the RCA, mainly the PL. There's a large ramus branch, which is diseased in the proximal segment. And I think you can all appreciate the calcification in these vessels. Now, pay close attention to the RCA. There's disease at the proximal segment, mid-segment, distal segment, and at the PDA with a CTO of the PL. And I think you can all appreciate the significant tortuosity. So this patient has significant three-vessel disease, very heavily calcified, syntax score of 50, and a Euro score 2 of 8%, and a syntax score 2 of 70 for PCI and 64 for cabbage, giving us both options. He was consulted for surgery, and it was very quickly turned down. Now the patient was referred to us for complex angioplasty. So why don't we discuss some strategy here?
Any CHIP operators or CTO operators want to raise their hands and take a hit?
I'm going
at
to take
this?
exception to this CHIP thing. All Canadians are CHIP operators. Okay, go ahead.
Tell us how you feel, Don. Why don't you move ahead and tell us what you did?
So initial plan was rotational atherectomy for the RCA, but significant complexity was anticipated from the get-go because of the heavy concentric calcification, the significant tortuosity, and the tandem calcified lesions in the mid-distal segment. Stage procedure for the LAD and ramus, with or without atherectomy, and medical management for the CTO of the circumflex and the PL. That was the initial strategy. So I decided to start off with the RCA angioplasty because I prefer to start with the most difficult vessel. So I took a femoral axis, 7 French long introducer for increased support. I took an AL1 7 French guiding catheter, and I planned already from the get-go to cross with a CTO specialized wire and a microcatheter, and then swap. So I took a Fielder XTA and a Turnpike LP 135 centimeters. Crossing the lesion was moderately difficult, and then I swapped for the rotowire. As you can see here, there was some moderate difficulty crossing with the microcatheter. Can you please come back one?
So is this a floppy wire or is it a stiff
Yeah, this was
wire?
a floppy wire. I think because of the significant calcium and the tortuosity, I didn't want to create any wire bias, so I chose the floppy wire. I started off with the 125 burr, and it was pretty difficult to get through. It took me about 12 passages, very patient, pecking at both lesions. I crossed the first lesion, then the second lesion, then the tandem third lesion, but it was quite difficult. Given the difficulty, crossing with the 125, I thought it was very necessary to cross a 1.5 burr. And then in the first passage, I get that sound. And you all know what that means. So very stressful situation. I start sweating and asking myself, what am I doing here? Then I start pulling, tugging and pulling, working at the pedal. Nothing is happening.
If I can ask, Mo, if I can ask you, we pull when this happens, but do you ever put it on Dynaglide and try to back it out?
I can't hear you well.
Do you ever put the system on Dynaglide when you're trying to back it out while you're still in the artery?
I tried everything. Dynaglide, rotablator, pulling, very deep intubation. I pulled with both hands. It was just not moving.
How about putting a parallel wire?
Pardon me?
Putting a parallel wire
I'm getting there.
and inflating a balloon.
The wire? Honestly, with the strength that I pulled on this system and having stuck burr before, the heart was moving with my hands, and I did not think pulling on the wire would change.
Mo, I had this situation once, and what I saw one case report that worked is that you cut the rota cable and you put a guide liner in to apply pressure at the head of the rota, and that worked actually, instead of, but I don't know if that would have worked in this case, but in my case.
As I told you, I brought down the 7 French guiding all the way to the mid RCA, and it was almost close to the burr, and with the amount of pull I had, I did not believe bringing down a guide liner is going to add any benefit at this point.
So, Moyan, have you tried pushing actually on it to try to free the burr? So sometime when it gets stuck,
I did try that.
Our reflex is to pull.
There was absolutely no movement. It was stuck, jammed. I tried to advance.
Did you try to go subantimal? Create a plan?
I'll get there.
You will get there. So this is the only way that you can relieve it, by doing a subantimal plan and inflate a balloon to relieve the distal tip of your burr from there.
So after all the pulling, I tried to cross beside with a Pilot 200, a Fielder XT, but didn't work.
Can I just, before you go on, Mohammed, this has happened in our lab, and whenever it happens and we can't get the burr out, we go for surgery, it's broadcast. Both times it's happened in our lab in the last 6-7 years, it's with a 1.5 burr. I've never seen this with a 1.25. I don't know if there's others here that have witness that. But it is the shape of the burr. The 1.25 is much more of a teardrop, and the 1.5 is much more of a diamond sort of shape where you have trouble, you're catching the back end of the burr. And I'm interested to hear if there are others who have seen this entrapment with smaller burrs.
Benoit?
Fortunately, I don't have a lot of experience with stock burr, but where in New York, where I did my fellowship, they had the total opposite, where they never use a 1.25 because all their experience with stock burr was with the 1.25, where because it's an olive shape, that it passes through the lesion, but it's not able to come back. And the 1.5, since it's bigger, so it coming back is easier. So
this case would suggest otherwise, right?
I agree. But one of the thing about pulling back with the when you have a stock burr is the shaft of the rotoblader is elastic. So if you just pull, you're not transmitting the force to the burr. That's why the shape of the guide wire, so that's why it's a 0.014 at the end. So when you bring back the wire and at the end, you're not going to be able to bring the wire completely in, but at one point you're going to be opposed to the burr, and then you try to bring it as a piece. That way you're going to be able to transmit more forces to the
Again,
burr.
Ben, you know, I've severed so many wires, and with the strength I pulled on this burr, I do not think that would have solved the issue. And with the complexity of this lesion, I'll bring it back.
He had not. He had tried to bring balloons, and he did it, and he unstuck the burr by bringing the wire and pulling the whole system together. So it's really a trick you need to try, or I think going in the other thing. You may
Mohammed,
lose
you've
your
got
distal position, but
10 minutes, so let's hear what you did.
Let's move it forward. Okay, so we've been through the motions. Let me just move forward. So at this point, I did not have good access. I wanted to make sure that I can deliver material and everything I needed. So I obtained the second 7 French axis, decannulated my catheter, ping-pong technique with another AL1 guiding, and I re-attempted using a guide liner, microcatheter to cross beside the burr. But again, it was useless. There was just absolutely no space beside that burr to cross. And remember, there was a proximal lesion. There was dissection in the vessel. It was difficult to get down there. So again, it failed. So now I'm thinking, you know, we're CTO operators. We do this frequently. I think it's time to think outside the box. I'm unable to cross in the lumen around that burr. So maybe it's time to bypass the calcium, bypass the burr, and do something different. So we learned from CTO PCI that the subintimal space can be our friend. It helps us cross long distances of occlusion safely and efficiently, and it's expandable to about 1.8 times the luminal size. And it can bypass heavy calcifications. So we thought, let's gain access to the subintimal space and perform a subintimal plaque modification to facilitate the burr retrieval. And there are several ways we can use to access the subintimal space. We can either do a balloon-assisted subintimal entry, where we inflate a balloon just close to the proximal plaque. We create dissections in the vessel, and using our microcatheter and a knuckle wire, we can get into the subintimal space and bypass the undilatable lesion. Or we can do a scratch and go, where we use a penetrating wire like the Gaia 3 CP12 or the Hornet 14 to get into the subintimal space. And then we swap that for a polymer-coated wire, and we get into the subintimal space, bypass the occlusion. And then what is subintimal plaque modification? So it's a technique that we use in CTO PCI for resistant undilatable lesion. We use the subintimal space at the level of the undilatable lesion to crush the calcium and modify the plaque, and this permits the balloon and material crossing through the resistant lesion. So how do we do this? We have a wire across the lesion, we have a microcatheter at the lesion, and then we go in the subintimal space, and with a balloon, we externally crush the plaque. And that enables the passage and crossing of our material. So in this case, we approached a turnpike LP just beside the burr. Then we accessed the subintimal space with a Gaia 3. Then we brought down a Fielder XT, formed the knuckle, and then we pushed the knuckle in the vessel. And then the knuckle advanced into distal RCA, and then followed in the PL. And at this point, we're in the subintimal space. Then we progressively dilated the subintimal space with a 1.5 balloon, a 2.0 balloon, and a 2.5 balloon up to 3. And in doing this, I performed progressive traction on the burr, and then I finally managed to retrieve it. But it's not time to celebrate yet, because if you look on the panel on the right, you can see that with my pull, it was very forceful, but almost everything came out, and that's all I have left intraluminal. So remember, I have a wire in the subintimal space, I have the tip of the rotawire through intraluminal, and that's where I am right now. And I have a floating guide catheter in the aorta. So I think if I lose this, I'm probably going to lose the vessel. I'm not going to be able to get it back. So what I thought is that we use balloons to trap material in guidings in CTO PCI. So I think I can apply the same principle in the subintimal space. So I had my 3.0 balloon already there. I inflated my 3.0 balloon in the subintimal space, and I trapped my wire. And in doing this, this enabled me to remove my burr and bring down a microcatheter and secure my vessel. Then I advanced my microcatheter, another turnpike, into the more distal RCA, and then I passed a supportive workhorse wire. And then the rest, I brought down a guide liner, did aggressive predilatation of the vessel, and then I ended up stenting. This was the final result.
Nice result.
So, as you can all see, we used 150 of dye. Procedure time was 4 hours. Radiation dose, we are completely fried. Fluoroscopy time, 90 minutes.
Is that 6 gray or 60 gray?
60.
60 gray. 60.
Must be 60.
BMI was 45. 4-hour time. You can say we were patient.
Wow.
A patient was discharged at 48 hours, and the LAD and Ramus were staged as an outpatient, and we submitted our case to JACC Interventional case report, and it's currently under review. This is the traditional algorithm that was published in 2003 in Eurointervention, where it stops at cutting the shaft and pulling, bringing down a guide liner, and calling for surgery. They updated this in 2019 on PCR Online, where they mentioned some CTO techniques or mini-star technique, but that's not what we used. We did a subintimal entry and subintimal plaque modification, which is not mentioned on the algorithm. So my take-home message is, I think burr entrapment, despite all our advancement in techniques, still remains an interventionist's worst nightmare. I advise you to call for help, call a colleague to help you out, and call your surgeon. Go methodically through the algorithm for burr entrapment, and if you're at ease with this, consider advanced CTO techniques to retrieve your burr. Thank you very much.
Mohammed, that was really excellent, and it's a wonderful example of you thinking on your feet. I love the idea of entrapping. You had a problem with entrapment, and then you used trapping in the intimal space, your luminal wire, which I think was fantastic. So I'm a little concerned about the gray, but that's a great result at the end for the patient's coronaries. I'm going to leave it now with Dawn to wrap up.
Do we have another comment there before I close? Anybody else final comments? As I was walking up to the podium, Dean shared a reflection with me saying that, you know, these cases are amazing. These patients are so sick And it seems like we're never sending the message that there are things that we can't do. It seems like we're always sending the messages, well, we're going to try it, and then we'll figure out a way to get out of it. I'm not sure that that is the right message, but it's very impressive to watch, what goes on in this country. And, I just want to say thank you to the presenters, thank you to the moderators, and the organizing committee. We have so much to learn from each other. We have so little time to do it. And, I think that this symposium continues to deliver every year because of you guys, because of us, because of the whole country and our experience. So, when the call comes out for cases for next year, don't hesitate. We need to share these cases. I just learned so much just watching, and it's been a few years I've been doing this. So thank you very much.